Good afternoon, everyone. My name is Shannon Kepka, and I'm a project manager working with the nursing home teams in New Mexico from Health Insight. I'd like to welcome you to our half-hour Hot Topics series. These webinars are designed to provide you great ideas on antipsychotic reduction strategies in a 30-minute time frame to accommodate your busy schedules. They are brought to you by the New Mexico Statewide Partnership to Improve Dementia Care Work Group and sponsored by the New Mexico Department of Health, New Mexico Healthcare Association, and Health Insight. So we are very excited about today's presenter. Dr. Janice Knoefel is a neurologist and geriatrician with 35 years experience. She has trained in internal medicine, neurology, geriatric neurology, and public health. She's been on the faculty of the University of Cincinnati, Boston University, and UNM, where she's professor of medicine and geriatrics and neurology. She participates in clinical care, teaching, and research. She is interested in neurological diseases of aging, most importantly, Alzheimer's disease and dementia of all types. She's the clinical director of the Memory and Aging Center at UNM's Clinical Neurosciences Center. So, Dr. Knoefel, you may get started.
Thank you, Shannon. Once again, thank you for inviting me to present. This is a topic near and dear to my heart. I see patients with Lewy body pretty much every week, and I'm sure you do too, you out there in the facilities. Okay, good. So I'm going to get right into the meat of it. We call it dementia with Lewy bodies. That is purely a tissue diagnosis, and but what we see are what you have listed here already. There are core clinical features that help us to distinguish this from other types of dementia. So 3 of the core clinical features occur early and persist. Now, you might not see them all at one time. I believe by the time our patients get to the long-term care setting, they will have established pretty much all 3 of these symptoms. So the symptoms are fluctuation in the functional cognition, recurrent visual hallucinations, and also a sleep disturbance, which we call REM, sleep behavioral disorder. REM stands for rapid eye movement sleep. That's the period of time during our sleep cycle that dreams occur. So those are the 3 core clinical features. There is another core feature, and that is Parkinsonism. And how that manifests itself is by generally slowing down, and that can be motor as well as cognitive abilities. What we see clinically when we test is limb rigidity, and that's what you would see would be the person appears to be stiff, not moving normally and naturally, not at all gracefully like they had when they were younger. We also see it as a lesser degree of spontaneous movements. We call it dementia with Lewy bodies because dementia is an essential feature. Dementia, again, defined as cognitive decline in cognitive function from a previous level of function. Now, as opposed to Alzheimer's disease, memory impairment is not necessarily in the early stages of this illness. It's not necessarily the case the individual and their family are going to come complaining of memory problems. They're going to be complaining of some of these other difficulties that we just talked about, the core clinical features. So what we do see with cognitive decline in patients with Lewy body dementia is that the attention and the visual spatial ability is impacted very early on. It might be the first symptom, and certainly when we test it in clinic, it is very impaired. And again, compare that to Alzheimer's disease, where memory is the first and worst symptom that we experience. We do have treatment for this form of dementia. It's also the medications that are FDA approved for Alzheimer's disease. So those 2 classes of medicines can help the cognitive decline that we see in patients with Lewy body. So let me talk a little bit about the another core feature, and that's the fluctuation. So fluctuation of cognition is defined as a wide variation in alertness and in attention on a day-to-day basis. So the result of this is sometimes patients with Lewy body will have very, very bad days. I mean, bad like you have never seen before. And other days are very, very good days when, believe it or not, the person can almost seem like they're back to their normal, usual self. It's remarkable fluctuations. It's important to note that the very bad days occur after a poor night's sleep. And if you think about our own selves, and also perhaps if you have young children, if there's a bad night's sleep, the next day is not going to be good. And that really applies to our patients with Lewy body. So the take-home lesson from this core feature is that the intermittent confusion and that fluctuation is part of the illness. It's not due to other common medical conditions. So for instance, there will be no urinary tract infection. That's not part of the illness with the Lewy bodies. And I'm going to throw in a couple of cases. These are the cases that I know. I took care of a gentleman whose very first symptom was 3 years previous. He was on a tour of the Middle East, and he suddenly developed confusion, agitation, and disorientation after a long flight from the United States to the Middle East. That's a really long journey. He ended up having to be medically evacuated from the tour ship. He was hospitalized overnight. He miraculously recovered, probably because he got a good night's sleep. He returned and he completed the tour. Remarkable. 3 years later, he had developed additional symptoms. He came to my clinic and we were able to give him the diagnosis. It's important that we have education on the fluctuations because many of these remarkable changes, just like in the patient we just talked about, will result in people being sent to the emergency room where they will be evaluated, usually scanned, blood tests, usually given IV fluids, and often sleep, right? So they sleep, they get better, and then they go right back to the facility in an improved condition. So one patient that I had with Lewy bodies, he was in the emergency room 17 times over 2-year span. And that's because the relationship of his illness to those fluctuations was not recognized. So take home point, fluctuations are part of this illness. So now let's talk about the REM behavioral sleep disturbance. We abbreviate it as RBD. So the REM behavioral sleep disorder may precede the cognitive decline by many years. So how do we know this person has a sleep disturbance? Well, they start to become very active sleepers. They will sometimes act out their dreams. They might vocalize, they might verbalize even during REM sleep. That is what we call dream enactment behaviors. In other words, they're acting out their dreams. It's important to understand that sleep-related injuries might arise. I had a gentleman who fell out of bed. He hit his eye on the bedstand and ended up going to the emergency room to get that treated. So a lot of very active sleep. And it stands out because 10, 20, 30 years ago, the person was a peaceful sleeper. And over the number of years, they have developed much more active sleep, which is what we call REM behavioral disorder. It's important to also understand that just because a person's acting out some of their dreams, it doesn't necessarily mean they have dementia with Lewy bodies. REM behavioral disorder can also be seen with Parkinson's, a number of other degenerative conditions, PSP. It can be seen in narcolepsy. If you have some type of a brain tumor, you can also have this kind of behaviors. And again, another take-home point is REM behavioral disorder can be exacerbated by certain medications. And if you look at the medications I have here on the screen, antidepressants, very commonly used. and also Parkinson's meds, not as common as the antidepressants, but still very common. So here's another short case, a 79-year-old woman. She does have a history of depression, and she has had very effective treatment of her depression with an antidepressant class called SSRI. She did develop symptoms of REM behavioral disorder over 4 years. Those symptoms improved when we stopped her SSRI. Then she developed, 2 years later, more symptoms of Lewy body dementia with cognitive decline, episodic confusion, and again, that RBD started to come back on her and get worse and worse. So we recognize this as the prelude to her actual diagnosis with Lewy bodies. So now let's talk about hallucinations. Visual hallucinations is another essential core feature, clinical core feature. Visual hallucinations might develop early on in the illness. The visual hallucinations, again, they're seen during the waking states and can be very well-formed images of people, animals, often small children. The presence of the visual hallucinations is usually underreported, either due to poor insight on the part of the individual or non-distressing content. So what they're seeing is not disturbing to them. It's people, and generally they're not threatening. It's not unusual for the person to interact with a hallucination in terms of talking, trying to interact with them in terms of going places, or come sit with me at the table or something like that. There is a critical distinction to be made, and that is with Alzheimer's disease, it is very, very, very rare to actually have hallucinations. You might have suspiciousness, you might have some paranoia that people are stealing from you, but you will not, as a rule, have visual hallucinations. If you have a person with dementia who is having visual hallucinations, we must think of dementia with Lewy bodies. So here's a small case. 88-year-old gentleman who just happened to have been an Army general. He was very high up, and he was in charge of the human resources for the Army. So he was very high level. He came to me with a history of 3 years progressive dementia. He had severe level deficits on all the cognitive tests that we did. He was a very agreeable gentleman, very nice. He was cooperative for home care by his wife and other care providers. When I asked his wife, well, what does he do with his time during the day? She told me that he works in the office every day. And I said to myself, how can that be? And then she explained to me that he thought their living room was his office, and he was in the living room all day long. He was directing his office staff on how to take care of business. And that kept him occupied all day long, and she was very happy with that. But we know that he was not doing that. That was a hallucination to him, and it was actually a very complex, repetitive hallucination, which I have to believe was somewhat comforting to him. He was not distressed, his wife was not distressed, but I wouldn't have known that if I hadn't have asked about that. So if you don't think things have been strange so far, let me get into the strange part of this discussion. So hallucinations per se are not a symptom of psychosis in this condition. It's the visual hallucinations are a symptom of a REM sleep disturbance, because what is happening is that REM sleep is intruding upon our waking state. The brain, humans need REM sleep on a regular basis because it's essential to our health and to our function. So if a person is not getting enough REM sleep, if we stayed up for 3 days in a row, all of us, we would start to see hallucinations because it's dreaming. The visual hallucinations become worse if the person with Lewy body is sleep deprived. So I'll leave it up to you. What's the best treatment? The best treatment is effective sleep. Many of our patients with Lewy body dementia end up on antipsychotics. And antipsychotics are good medications for people who are having psychotic hallucinations, either visual or auditory. Antipsychotics are not effective in patients with dementia with Lewy body. It may appear that they are effective, but they're effective because they have a non-specific sedation effect. So people become sedated, they become sleepy, they might sleep more. But we all know from listening to these seminars that the use of antipsychotic medications is quite dangerous. Although we might not recognize it at the time, the effects over a prolonged period of time do become dangerous and fatal in many instances. So I'm going to move on now to another core feature of dementia with Lewy bodies, and that's Parkinsonism. So again, how we will see this in the person's movements is that the movements are slowed down, very, very much so. The person can still move, but they're just very slow. In general, the tremor is not present. Tremor, by definition, is that there is a movement of the limb when the limb is at rest. That is best described in actual Parkinson's disease, not as a symptom of Parkinsonism. Another symptom includes rigidity, which is defined as an increase in the muscle tone. And the person you would witness the person to be stiff. The stiffness can occur in the head and the neck. It can occur in the trunk, and as well as in the arms and in the legs. So how this is seen is there's changes in walking, in speech, in facial expression, and certainly in intentional movements, such things as eating, or manipulating objects. Generally, the Parkinsonism is not of a severe enough degree that it would actually be a functional disability. So in general, the individual can still do what they need to do, including walking and eating and talking, etc. But it's just slower, and in some instances it's a little more effortful. But they can still do it. So it's not a functional disability to them. However, the presence of the Parkinsonism really helps us to steer our diagnosis towards Lewy body dementia rather than any of the other types of dementias. So, I told you about the strange part. Now I'm going to get into the dangerous part, okay? Individuals with Lewy body dementia have extreme sensitivity to antipsychotic medications, and how this manifests as dramatic worsening of that slowing down behavior of the Parkinsonism. There's a 30 to 50% incidence in individuals with Lewy body who have this extreme sensitivity to antipsychotics. And it's not dose related. You can have the lowest dose possible. If that builds up in your system over a few weeks, you can get into extreme slowing down to the point where you cannot move at all. If this happens, there is a 200 to 300% increase in mortality. And for the most part, again, that type of reaction is not seen in Alzheimer's disease. So I'm going to give you another one of my cases. So this is a young woman, 59 years old. She did have a history of cognitive decline. She has a new diagnosis. Well, actually, after she came to me and we did the full evaluation, she definitely does have dementia with Lewy body. She was not on any treatment yet, still living at home. So she was at home all day while her husband, who I believe worked for the highway department, was doing his job all day long. She lived about 250 miles from Albuquerque, so it was not really convenient for her to come in and see me, of course. She started having some really bad days. She became highly agitated and was admitted to a behavioral health unit. She was treated with high dose of antipsychotic medication. She was in the hospital for 2 weeks, and then she was discharged home on hospice because she had deteriorated so much with the use of those antipsychotic medications. So at that point, by that time, we were able to get her in to University of New Mexico behavioral health unit. We tapered her off of those medications. We put her on more appropriate medications, and she was able to go home and live with her husband again. And that's about a year ago now. She is still living at home with her husband, although she's not alone during the day anymore. So it was a dramatic, this is a dramatic illustration of that extreme sensitivity. So the flip side of that, notice I'm using the word extreme again. There is extreme sensitivity to the effects of carbidopa-levodopa medication. That's also known as Sinemet, if you will. So an individual with Lewy body dementia who is given carbidopa-levodopa has dramatic worsening of those visual hallucinations. It's almost like they're in a status effect of these visual hallucinations. So this happens to anywhere from 50 to 80% of people with Lewy body. If they get the carbidopa-levodopa, they're going to get this dramatic deterioration. Again, it's not dose related. Even a low dose of carbidopa-levodopa will allow this to happen. Again, a 200 to 300% increase in mortality. And again, such reactions as this are not seen in Alzheimer's disease. So if you have that by history, that really, again, points you in the direction of a diagnosis of dementia with Lewy bodies. So I've told you what not to do, right? So what kind of treatment do we have? Well, believe it or not, melatonin. Melatonin is an over-the-counter medication, which can be very effective. And I dare say that some of us listening to this webinar today are probably on melatonin ourselves, especially if you work nursing shifts at irregular hours. You may be on melatonin. Well, melatonin is the best initial treatment for dementia with Lewy bodies. And that's because it targets the sleep. You know, good consolidated sleep will make for a good day the next day. So we often will start with, well, we do start with low dose of the immediate release at bedtime. And we can go up slowly on the doses to improve the symptoms that we see. So our target symptoms would be consolidated, peaceful nighttime sleep, plus hopefully minimal or non-existent daytime hallucinations. If the individual is able to get to sleep nicely with the immediate release, but then they wake up, then we can also give an extended release formulation of melatonin, which is readily available, again, over the counter. So the melatonin, immediate release alone or immediate release supplemented with extended release is the best treatment. Clonazepam can also be added on later on if you've pushed the effects of the melatonin to the limit and there is still some difficulty with sleep and daytime hallucinations. Low dose clonazepam, literally a half a tablet of the lowest dose we have, can be also very effective as add-on treatments. The clonazepam and melatonin, actually, they do take a while to work, generally at least a couple of weeks. So don't give up on the treatment, just keep at it. It's also very important to recognize the danger of injury. So a safe environment is very important, which again, I'm assuming throughout your whole facilities, you take this to heart and there are no unsafe environments there. Some individuals will need daytime naps, in particular if you catch people sleeping in their chairs. It would be good to have that individual actually laying down in a restful position and getting a good daytime nap. So that's not such a bad idea. Okay, so treatment for hallucinations, again, emphasizing adequate restful sleep. So here's a good question. Do you intentionally wake up your patients? So if you think about it, if you have had a couple of bad days yourself and you know you have a sleep deficit, do you really want to be woken up after a 7 or 8 hours sleep when you really need like 9 or 10 or 12 hours to replenish your sleep? So I would say, if at all possible, do not intentionally wake up these patients with Lewy body dementia. Allow them to sleep. If they're sleeping, allow them to sleep. Isn't that a principle that we keep with our younger children? If they're sleeping, they need to sleep. Let's let them sleep. So the treatment for hallucinations, very much the same treatment for REM behavioral disorder. Again, the melatonin, add on clonazepam as needed. If there are no risky behaviors during the day and they're having a hallucination, you don't necessarily need to intervene. So we've missed the opportunity for that day, but let's aim for another good night's sleep and see what the next day brings us. Again, I would really recommend just do not use antipsychotic medications in this group. I have to tell you, I very rarely in my practice will ever use antipsychotics, period. I have maybe one Alzheimer patient a year who is becoming very suspicious because they're having memory problems, and I use them very gingerly in those populations. I do not use antipsychotic medications for behavioral control. Use them for suspiciousness, paranoia, etc. We do have alternatives to the antipsychotic medications. Antidepressant medications can work well. Anti-anxiety agents can work well too. So we really need to look for alternatives to the antipsychotic medications. And I have to tell you, I felt this way even before I became aware of the work that Health Insight New Mexico is doing. So this is my true feeling about those agents. Let's move on to the treatment for Parkinsonism. Generally, the Parkinson symptoms are not severe enough to treat. If the Parkinsonism is not interfering with their function, yes, they do things more slowly, but they can still do things. I would say we do not need to treat those Parkinson's symptoms. We know that the Parkinson's meds worsen the RBD, the REM behavioral disorder, so we really should leave those to the patients with diagnosed Parkinson's disease, not who have Parkinsonian symptoms. I would recommend supervised exercise for individuals who have a degree of Parkinsonism, such things as stationary exercise bikes under supervision with your therapy department would be great. Again, establish a safe environment and reduce the fall risk. So, in summary, dementia with Lewy bodies can be difficult to diagnose and treat. There are multiple symptom and treatment targets. What we have here are dementia as a target, yes, Parkinsonism, the REM behavioral disturbance /sleep, and the visual hallucinations. We know these individuals are susceptible to treatment side effects, so we have to be ever vigilant. And I have to tell you, I think I neglected to put something on this slide. We talked about dementia as one part of the symptom complex here with Lewy body. Well, the exact same medications that we use to treat the cognitive decline with Alzheimer's disease are also FDA approved for our dementia with Lewy body patients. So the cholinesterase inhibitors as a class, and also the NMDA antagonists as a class, are both approved for treatment of patients with Lewy body. And the FDA has approved these treatments because the evidence, the research studies have been done that shows those two classes of medications are effective. Just like Alzheimer's, there's no cure for dementia with Lewy bodies, but the FDA-approved medications can be very helpful with functional stability over a long period of time. I like to think that we give our patients with dementia the best opportunity we can to allow them to be stable and comfortable with their illness, and the dementia medications will also help them do that. And I don't know where I am on time, but I think we are up to the questions.
Yes, we are, and thank you. That was really interesting. We have a couple questions in the chat, but I'm going to remind folks, if you do have a question, please go ahead and enter it in the chat box so that we can ask Dr. Knoefel. And we'll get started. We had Haley who had asked, and I think you had started to address this, but what is considered more appropriate medications than antipsychotics for people with Lewy body, dementia with Lewy bodies?
And again, it's important to understand, well, what is our exact symptom target? Is it the hallucinations? Is it the sleep? Is it the dementia? Is it the Parkinsonism? For the fluctuations and the behavioral control, the best thing is to look for other underlying symptoms, such as perhaps underlying anxiety. Many of my patients with Lewy body will have an underlying anxiety because they don't understand what's going on. They don't understand why you're not helping this lady with her little girl who are in trouble. So that engenders a lot of agitation. If the individual is sleeping well at night and they're not having any visual hallucinations, if they're already on clonazepam, that low-dose clonazepam we talked about, if something is needed during the day as well, it is best to use medication that the person's already on. So I would recommend, again, a very low dose, 0.25 milligram of clonazepam can also be supplemented during the day. But I would challenge you to help the person understand, why are they agitated? Are they agitated because they're having those visual hallucinations? And I think there's a high likelihood that they are experiencing the visual hallucinations, and that's why they're becoming agitated. I had a gentleman in my clinic the other day, if you don't mind me giving you another example. He was seeing men in camo with guns in the trees out in his backyard. And he couldn't understand why nobody else was concerned about this. So yes, you bet he was agitated, but we don't need to give him necessarily something to calm him down. We need to get him more consolidated sleep so that he's not having this REM intrusion into his waking hours. So again, try to get in and really explore why that person is becoming agitated.
Okay. And Dr. Knoefel, Lena had asked if you can discuss what you do with residents that have extreme delusions also making them agitated.
And again, I would say, what is their underlying diagnosis?
Mm-hmm.
Is it Alzheimer's disease versus people with Lewy body dementia? If it is Alzheimer's disease, a very low dose. So, as I say, start low and go slow. So start with the lowest possible dose of an antipsychotic, generally an atypical antipsychotic. Give them at least a month on that dose before you decide that it needs to be increased. But again, I would challenge us to never use antipsychotics in an individual who has a diagnosis of dementia with Lewy bodies.
Okay, got a couple more questions. I understand people's time, might be up in terms of your availability, so certainly jump off if you need to, but we'll keep going for a few more minutes. And I'm going to combine the questions, if that's okay, thinking that you might be able to discuss them. We had a question from Kathy on whether other forms of dementia had hallucinations as a symptom. In other words, vascular dementia. Are hallucinations rare in dementia diagnoses? And she noted that you had said Alzheimer's disease generally does not. There was another question on what counsel can you give us for a resident who's sensitive to most meds, including antidepressants and anti-anxiety medications? And then another question about does the Parkinson's disease cause Lewy body, or is it the reverse? Two different things. So.
Okay, let me answer that last one first. Okay. So yes, Parkinson's disease does not cause dementia with Lewy body. They are two separate diagnoses. They may have some overlapping of symptoms. So that's why it's important to really ensure that you have an accurate diagnosis for that. A person with Parkinson's, if they, with your usual run-of-the-mill typical Parkinson's symptoms, if you have Parkinson's disease for 5, 10, 15, 20 years, you most likely are going to have cognitive decline. And in fact, we have this category called Parkinson's disease dementia, PDD. Those individuals will have less of an effect, less of a benefit to the use of the carbidopa, levodopa, and other meds over time. So their Parkinson's disease symptoms are not responding as well. Those individuals also respond to the 2 FDA approved classes of medications. So people with Parkinson's disease dementia should also get the benefit of the standard treatment with the FDA approved medications. The trick in people who have Parkinson's disease, for the most part, they have been on carbidopa, levodopa for years, maybe even decades, but the effects are wearing off, and the individual's resistance to the side effects of the carbidopa, levodopa is also decreasing. So it's not unusual, actually, in persons with treated Parkinson's disease to actually have visual hallucinations. And that's a direct effect of the medication on their brain. So that's a very difficult situation to manage. We end up having to decrease significantly the carbidopa, levodopa doses in those individuals. So that's you need an expert neurologist to really help with those kinds of decisions. So Shannon, what were some of the other questions?
Again, I think you addressed most of them. Was just working with residents sensitive to other medications, including antidepressants, anti-anxiety medications.
Okay. And as you know, everything in life is trial and error, right? You try something, if it doesn't work, you go on to the next thing. I would have to be, understand specifically what the exact troublesome symptoms are. If somebody is, quote, sensitive, I'm assuming that's to say that they're having a lot of side effects with those medications. We know the elderly need very low doses of medications, and older people who have neurological disease need even lower doses. So if a person is having a side effect to a certain medication, you might try going down on the dose and seeing what the effect is. Another principle that I will bring to the group is that the brain separate from the body. I mean, it's not really separate from the body, but it's a protected organ. And if we start taking a medication today in a steady dose, it might be a whole month before that the brain gets to be in a steady state of that concentration of that medication. So none of these medications are going to work instantaneously. We have to really, again, start with a very low dose and go slow. Do not increase even every week. I mean, for medications that work because they're accumulating in the brain, generally we go up on the doses about once a month, if even that. So we have to start low with those medications and then go slow.
Great. In the interest of time and getting you all back to your Friday, I'm going to say if you have any additional questions, you can enter them in chat, but what I might do is take this offline with Dr. Knoefel to make sure that we answer anything if there's lingering questions there. But I'd like to say thank you very much to Dr. Knoefel. This was wonderful and really very informative. This presentation is going to be posted to our website in a few weeks. So I encourage all of you to check out our posted webinars there on our nursing home library. I put the link into chat. And please share with any of your colleagues who couldn't make it today, or use it to in-service your staff who, again, were unavailable for this session today. Again, for continuing ed credits for New Mexico teams, please make sure I have your name and all attendees who were present. Make sure I have them in chat or email me afterwards so we can send you a test link. And I'm going to invite the group to join us on November 16th for our next hot topic, which is going to be pertaining to, I believe it's sleep and dementia we talked about, Dr. Knoefel. It's a little to be determined, but we're working that out. So once again, I'd like to thank our presenter, Dr. Janice Knoefel, for sitting with us today, and thank you all for attending our Hot Topics webinar today. Have a delightful Friday and enjoy your weekend.